discuss the hazards of labeling an adnexal lesion as complex. This was a 45-year-old multipara who presented with a history of abdominal pain and abdominal uterine bleeding of 7 years duration. She was diagnosed with a complex bilateral adnexal mass on ultrasound, for which a CT scan was requested. To me, this was an overkill to request for a CT scan when the ultrasound morphology was classic of mature cystic teratoma. In Nigeria, over 70% of patients pay out of pocket. This woman is a full-time housewife. Her husband is a retiree. So one can imagine the financial burden imposed on this family because of the level of an adnexal lesion as complex. For us in the Ayata family, we discourage the use of complex to describe adnexal lesions, describe the morphology, and give differential diagnosis. That is why I believe that there is a need to build capacity on how to identify especially common adnexal lesions. This was the CT scan, which is requested for after a description on ultrasound of a complex adnexal lesion. And the radiology showed me that this is the mass with a fat fluid level, and you can see an echogenic spot here. Now, when I did the ultrasound scan, after reviewing the patients, after, of course, having wasted her resources on a CT scan, not this full bladder or overdistended bladder, making the uterus axial in nature, and look at the lesion here. Which is heterogeneous, mixed echogenicity, and shadowing. And the second one, look at it here. Look at the Rokitansky nodule, the bright lines and dots. This is classic of mature cystic teratoma. So there was no need to request for additional imaging modalities. If this was not described as complex, probably the physician would have requested for a CT scan. So it's always important to describe the nature of the lesion rather than describing the lesion as complex. Now, this is looking at the modified benign simple descriptors. Here we can see the benign simple descriptor 1 to 4, and this is the area of focus. Benign simple descriptor 2 is a unilocal cyst with mixed echogenicity and acoustic shadows in a premenopausal woman, suggestive of benign cystic teratoma. Right. So let's see this lesion. Unilocal cyst. This is a unilocal cyst. Remember that the fat globule in a dermoid is not considered as a solid lesion. So this is a unilocular cyst, and you can see that here the measurement is less than 10 centimeters. So unilocular cysts with the mixed echogenicity. Look at the mixed echogenicity and acoustic shadows. Look at the acoustic shadows here. Look at the acoustic shadow here. Here giving the appearance of tip of the iceberg, and not these bright lines here, which represents here. And you can see somewhere here, you can see an echogenic lesion here, casting acoustic shadow, casting acoustic shadow. So this is classic of benign cystic teratoma. Now, this was the left ovary. You can see ergogenic areas here with shadowing. So, it's a case of bilateral mature cystic teratoma. At laparotomy, it was the left, right. It was after total abdominal hysterectomy and bilateral salpingo ovectomy. So, on cutting the lesions, look at this on the left side. Look at this fat ball, not the hair top here, and again, not the Rokitansky nodule, and not the content of the cyst. Again, you can see this is the left ovary, the right cyst, beg your pardon, the right cyst. So not the content here, not the content. This is the Rokitansky nodule here, Rokitansky nodule here. Look at this shadowing probably coming from this here, tap. Now, this is 3D of the same case. Here you can see the Rokitansky nodule, the cyst content, and the cyst wall. So here comparing the ultrasound image with image at laparotomy. This is the Rokitansky nodule. You can see this is the Rokitansky nodule. On opening the Rokitansky nodule, you can see this mesh of hair, which is represented probably by this area here, and not the sebum, and not the appearance of the content of the cysts. Again, just comparing the 3D image with the image at laparotomy. So now, what are the hazards of labeling this lesion as a complex lesion? The financial implications is huge, especially in an environment where majority pay out of pocket expense, especially for hereditary. What about the radiation hazards? This would have been avoided if the proper description was obtained on ultrasound scan. What about the psychological implication of telling the woman that she has a complex lesion and she has to do an expensive, high-stake investigation for us to define what the problem is? And on CT scan, there was an additional differential of mesenteritis. This will blur the judgments of the physician, and that would lead to delay in taking decisions. So these are many more of the hazards of describing a lesion as complex. So as much as possible, describe the lesion based on the morphology and give differential diagnosis rather than making an impression of a complex Adnexal lesion. Thank you.